Welcome to the Demystifying Medicine YouTube channel. This video is meant for educational purposes only and is not meant to be medical advice. Please consult your healthcare provider for any healthcare concerns. This video aims to draw connections between various clinical skills taught to medical learners and their anatomy correlates. Next time you're performing a shoulder exam or having one performed on you, hopefully you'll think back to what you learned from this video.
Your rotator cuff is made up of four muscles. From the posterior view, we have the supraspinatus and infraspinatus, which are just superior and inferior to the scapular spine. We have teres minor, which is inferior and lateral to the infraspinatus. And then anteriorly, we have the subscapularis. We will be walking through the different physical exam maneuvers that can be utilized in order to test each of these muscles, as well as determine whether or not there is injury. However, keep in mind that often a test is positive in more than one pathology, and multiple muscle groups can elicit a positive on the same test. The first muscle that we're going to be looking at is the supraspinatus. This muscle originates from the supraspinous fossa of the scapula and attaches to the greater tubercle of the humerus. For this first test, you're going to ask that the patient perform full shoulder abduction to 180 degrees before returning to starting position. This is what a normal test should look like, with no pain or weakness. In the case of a torn supraspinatus tendon, you might see a drop arm, like the example on the left-hand side, where the patient's arm suddenly drops when returning back to baseline position. Or with a supraspinatus tendinitis, you might experience pain with this test, for example, in the right-hand video. An alternative test to check for a torn supraspinatus tendon is a chop arm test. With the patient's arms abducted to 90 degrees at their sides, you're going to chop down on their arms, and if there is a fully torn supraspinatus tendon, the affected arm will drop to their side. Lastly, we're going to conduct the empty can test. With the patient's arms abducted to 90 degrees and brought forward anteriorly with 30-degree flexion, you're going to ask the patient to point their thumbs down. From this position, you're going to put downwards pressure against the patient's resistance and check for pain or weakness. Next, we will be assessing the infraspinatus muscle, which originates in the infraspinous fossa and inserts at the tuberosity of the humerus. To assess the infraspinatus, we're going to ask the patient to flex the elbows to 90 degrees. We're then going to ask the patient to externally rotate their forearms against our resistance. A positive test would be indicated by weakness or pain. Keep in mind that a torn infraspinatus tendon is usually painless, so weakness is a strong indicator that there has been a tear. We're going to assess the integrity of the infraspinatus and teres minor using Hornblower's test. The patient is going to be asked to externally rotate against resistance, like last time, however this time in the horizontal plane. The test is positive if they are unable to perform external rotation. Now we will assess the subscapularis, which lies at the anterior surface of the scapula. It originates at the subscapular fossa and inserts on the lesser tubercle of the humerus. In order to test for subscapularis tendon tear, we're going to ask the patient to fully internally rotate the shoulder so that their hand is on their lumbar region of their back. Then we're going to ask the patient to internally rotate even further so that their hand separates from their back. In a normal test, the patient should be able to keep their hand from making contact with their back. If there is evidence that there is a subscapularis tendon tear and the patient is unable to keep the hand away from the back, then this is called a positive internal rotation leg sign. An alternative version of this test is called the Gerber's lift-off test. It is the same principle, however, this time the patient tries to lift their hand away from their back against resistance. A positive test is indicated by the patient unable to keep their hand lifted away from their back against resistance. Next, we will take a look at shoulder impingement syndrome, which is where the space between the acromion, known as the subacromial space, is narrowed, compressing the structures that lie within it. Notably, these structures include the subacromial bursa and the supraspinatus tendon. Therefore, you might hear the terms used exchangeably with shoulder impingement syndrome, supraspinatus tendinitis, and subacromial bursitis. We will now take a look at the physical exam maneuvers that can be used to examine if there is a shoulder impingement syndrome. You can begin by palpating the subacromial space, which can be accessed by requesting the patient have their shoulder in full internal rotation. A positive test is indicated by pain. Next, we're going to ask the patient to fully abduct their shoulders to 180 degrees before returning them to starting position. With shoulder impingement syndrome, you might notice that the patient has maximal pain between 60 and 120 degrees of abduction. This test might look familiar to you from when we performed it earlier in the video looking for a supraspinatus tendinitis. As we mentioned, these tests often look for multiple pathologies and can be positive in more than one instance. Also seen earlier in our supraspinatus tests is the empty can test, which can also be positive in a shoulder impingement syndrome. Again, a positive test here is indicated by pain. You can also perform Neer's test, which involves passive forward flexion of the arm while it is fully pronated. A positive test would be indicated by pain on the patient's face, as seen in the right-hand video. Now we will be using Hawkins-Kennedy test. In order to perform this test, the elbow and shoulder should both be flexed at 90 degrees, and the examiner will internally rotate the shoulder as much as possible. The test is positive if there is pain at the tip of the shoulder. In Yoakum's test, also known as Yoakum's maneuver, the arm is adducted and elbow is flexed so that the hand is placed over the opposite shoulder. The patient then raises the elbow passively without moving the shoulder. The test is considered positive if there is pain present in the shoulder tip. Oftentimes, shoulder pain is due to biceps tendinopathy. Your biceps brachii has two heads, a long head and a short head. In general, the long head of the biceps is usually what causes pain because it originates from the supraglenoid tubercle in the shoulder joint and overlies the humeral head. The short head of the biceps brachii originates from the coracoid process of the scapula. You can use Speed's test in order to assess for biceps tendinopathy. In this test, you're going to ask the patient to fully extend their elbow and supinate the forearm. The patient is then going to be asked to flex the shoulder against your downwards resistance as the examiner. The test is positive if the patient produces pain. You can also use Yergeson's test in order to assess for biceps tendinopathy. In this test, the patient is asked to flex the elbow at 90 degrees and then supinate the forearm against the resistance of the examiner. The shoulder joint is formed by an articulation between the head of the humerus and the glenoid fossa of the scapula. The head of the humerus is actually much larger than the glenoid fossa, which gives the joint its wide range of movement. However, it comes at the cost of instability. The glenohumeral joint is stabilized by the joint capsule, a fibrous sheath which encloses the structures of the joint. There are also several ligaments that play an important role in stabilizing the shoulder joint. As you see here in this image, there are two key ligaments that play an important role: the superior glenohumeral ligament and the inferior glenohumeral ligament. There are also several other ligaments which are not pictured here, including the coracohumeral, the transverse humeral, and the coracoacromial ligaments. Disruption of any of these ligaments can cause shoulder instability. We will now explore the physical exam maneuvers that can be used to assess for instability of the shoulder joint. In this first test, we're going to be assessing the sulcus sign. You're going to apply downward pressure on the humerus by pulling at the level of the elbow, and at the same time, observe the lateral aspect of the deltoid region. If a sulcus appears in this region, the test is considered to be positive for inferior shoulder instability. Next, we will test for anterior shoulder instability at the glenohumeral joint using 3 separate tests that are performed in succession. These tests are known as apprehension, relocation, and release. In the apprehension test, with the patient lying supine on the examination table, you're going to flex the elbow at 90 degrees and abduct the shoulder to 90 degrees as well. The examiner is going to apply pressure to the posterior aspect of the humerus to create a dislocation of the humerus that could cause pain or discomfort if there is an instability. For the relocation portion of the test, the examiner will now apply a downward pressure on the anterior aspect of the humerus. That will make the pain and the apprehension disappear if an anterior instability is present. For the last part of this test, the release sign, you're going to release the humerus and watch the patient's face closely to observe for any signs of recurrence of pain or discomfort. If pain is present, then this is a positive sign. That's all for this video. Thanks for watching. Feel free to check out the caption below for more anatomy resources, as well as resources for physical exams.